Good afternoon, friends. What I'm going to do in this roundtable discussion is to make a very brief presentation of where the STEMI program is running at the current time, both nationally and internationally, and then have the panel, which consists of people from different organizations. And I think this is going to be a very interesting discussion on how to take this program forward, both nationally and internationally. Now, we do know that a system of care requires multiple parts to work together. The ambulance service hardware that is used for recording ECGs, software to collect data, the diagnosis of ECG, whether it's going to be at the site or remotely, the various protocols that need to be in place, the training that goes into it, analytics for quality improvement purposes, and then the governance of this. So all this needs to work together. And we know the STEMI India study, which was published in JAMA, was a very successful program at many levels. At the individual level, it reduced mortality significantly at 1 year. At institutional level, it improved PCI and pharmacoinvasive treatment without increasing costs. So the throughput was increased, and there was a great amount of capacity building for staff at spokes where training happened as well as facilities were put up. And at the society level, we were able to show a cost benefit of 3.98 for every rupee spent in the program. And this is published in multiple journals. Now let's look at 3 different areas where this program has been implemented and what are the problems and how do we take this forward. And this is what our discussion should be today. Now, if you look at public hospitals, I think there are 5 states that currently are in different stages of implementation. However, of the number of states that we have in this country, 5 is a very small number considering that the data on this was being published over 4 years ago. Now, the outcomes that we've been able to demonstrate with this program is reduction in patient mortality, increase in patients with chest pain and STEMI approaching hospitals, better data and analytics so that we can understand where the gaps are, accreditation of hospitals so that people in the region know which hospital to approach when they have chest pain rather than go to the first or nearest hospital, improvement in EMS or the ambulance services to pick up patients with chest pain, and improving patient awareness. Now, the public program, now if you look at Tamil Nadu, the transfers from spokes to the hubs increased from 0 to 20 patients per month. In Gujarat, where we ran the program, it increased from 16 to 52 patients per month. From the spokes, in fact, it increased from 12% to 85% of patients. So the pharmacoinvasive treatment dramatically increased. In Punjab, it increased to 12 patients per month. In terms of treatment strategies, and we know that primary PCI and pharmacoinvasive treatment are the better reperfusion strategies. In Tamil Nadu, from something like 35%, that went up to 60%. In Gujarat, it went up from 35% to close to 55%. And in Punjab, the no treatment dropped from 28% to 13%. So significant changes in practice with the implementation of this program. And it was demonstrated in the outcomes also. In Tamil Nadu, you had a 3.4% absolute mortality reduction. In Punjab, it was close to 10% improvement. In Gujarat, there was a drop in mortality, but the COVID epidemic, the percentage of mortality went up, and that is probably related to both access as well as patients having a comorbid condition like COVID at that same time. Now, the STEMI India model worked because of the efficient use of the existing resources. It equipped the staff which were already present to enable them to run the program, thus improving the long-term sustainability of it. There was a flexibility allowing different models to work in different geographies and a dynamic change from one model to the other. And it was modular and scalable across the state. Now, why has it not picked up across other states. And this is something that we need to debate and to critically look at, because this is a program that has shown mortality benefits as well as cost effectiveness. And therefore, there's no reason any state should hesitate in putting this program forward. Now, we realize that governments are critical to running this program in the public sector because they control the key components of the program: the hospitals, the health insurance scheme, the ambulance services, and therefore without them, there cannot be an equity in STEMI care. However, the bureaucratic lethargy and that you see in officials is something that makes it very difficult to change the status quo. And we need to see how we can do this. Educating the political and bureaucratic machinery takes a lot of time. And for professionals like you and me, this is a very difficult thing unless there are other agencies which are also involved in this. And therefore, increasing advocacy, whether it's patient rights groups, social organizations like the Rotary or other social organizations, medical bodies, or even political parties. I think it has to involve each and every strata of our society if we have to take it forward. Let's look briefly at the global programs. Now, STEMI India has signed an MOU with STEM Save a Life, which is an offshoot, is an organization that is part of the EuroPCR, which is involved in a worldwide initiative to improve patient outcomes in MI patients. And together, this is now present in 33 countries. And together with SSL, we have now been able to start programs in South Africa, in Sudan, Egypt, and Kenya, or in the process of doing that. Countries that are chosen for these pilot projects require a strong local leadership and broad acceptability across the country. They need to have strong ties in both local government and ambulance services. And this we saw is so critical to running a program. Reperfusion therapy and ambulance services should be government funded. This is critical in LMICs because patient cannot pay out of pocket. And the initial part of the project, or the pilot part of the project, is funded by SSL, but subsequently we expect the government to take over. And preferably the initial pilot is run using a tripartite agreement between the global SSL, the local SSL, and the government. And we are seeing some progress. Recently, there's been some attempts to work, SSL to work with GATI, which is the ACC program in LMIC, and I hope that coming together of these two big organizations with the utilization of the STEMI India model and many of the tools that we use in our programs will help to take this program forward globally. Now, we do realize that it's not just in public programs that we need to look at STEMI programs. A large amount, about 60–65% of the tertiary care in this country is in the private sector. And therefore, it's critical that private hospitals are also part of this program. Now, we've shown that there is both cost benefit as well as mortality reduction, but private hospitals also need to be sure that they do not have, they do not pay out of pocket for many of these benefits without a sort of economic benefit, or to put it in lay terms, there needs to be a clear-cut business model that shows that there is both sustainability as well as profitability in running a program such as this. Now, we've just looked at a tentative costing that a private hub hospital, which may be connected to 15 spokes, would require to run a program like this. And it would cost approximately, for everything, the software, the hardware, the training, and to ensure that patients are optimally, there is enough public education in running the program. It would cost something like 2–2.5 lakhs a month. And if you were to actually look at a medium-sized hub hospital, which would do about 100 or 150 angioplasties in a month, it just means an additional cost of something like 2,000 rupees to be charged per patient to have a program like this run. And what it will do, based on the data that we have, is that it could increase the number of cases to something like 150 extra STEMI patients coming through for pharmacoinvasive treatment. And if you look at the cost, if you look at the profit that a hub hospital could make is significant. And therefore, both financially, in terms of mortality, in terms of cost benefit to the nation, I think that it's a totally win-win situation. And therefore, I think the private sector is one area that we need to rope in into this program because it's beneficial to the patient and to the hospital. Now, ideal hub hospitals should have a cath lab that is functioning. You need to get a buy-in from all the cardiologists, and they should have health insurance as part of it. And the spoke hospitals in those regions which are connected should preferably have thrombolysis capability and should be within a 100-kilometer radius of the hub so that they're able to be part of this program. There are three models that we've talked about. I'm just briefly showing you. In rural areas, we talk about purely a thrombolytic setup. In areas where within 2 hours driving distance, there is a hub hospital, we could think about the classical STEMI India hub and spoke model, where you have primary PCI in the hub hospital and pharmacoinvasive treatment in the spoke hospitals. Or in very urban areas, you could look at model 3, which is a primary PCI model, where ECG diagnosis is made peripherally and patients shifted directly to the hub hospital for primary PCI. So I'm going to stop here and say that all these can be achieved with the STEMI India assisting the programs within the public sector, in the private sector, or from the global perspective. The protocols are there. Mapping can be done by STEMI India. The training protocols are in place. Certification as well as utilization of the STEMI India software can be done. And the project operations, there can be hand-holding or directly run by STEMI India. So it is possible today to run a program. And I think this is an important session where I would like to hear from different organizations that are working in different areas. There is the scientific areas, the public health area. There is representation from trusts, as well as from rural doctors involved in thrombolytic management, so that we can hear what they have to say on how we can take this program forward in this country and globally. Thank you for that.